Good morning to all of you. IAPS is glad to partner Rajasthan APSICON 2023 for the opportunity to reconnect with friends, relearn and refresh the art of plastic, aesthetic and reconstructive surgery, as well as rejuvenate the mind and body for this scientific extravaganza organized by the Department of Burns and Plastic Surgery, AIMS, Jodhpur. I would like to thank Dr. Varsha and especially Dr. Pawan Dikshit and Dr. Shilpi Karmakar for the kind invitation. Most of the basics have been covered by Dr. Varsha about gynecomastia. The mandate given to me is to discuss about the management of grade 4 gynecomastia. I have no financial disclosures to make, and please avoid taking photographs or videos because some of these patients have not consented for the same. The aim in managing grade 4 gynecomastia in Indian context would be to minimize the chest scars, confine the scars to the periareolar area if possible. So it is important to counsel and stage the surgery to maximize outcomes. Once the scar is made on the chest wall beyond the NSE, it's a telltale sign of having had a gynecomastia surgery. This is a very important chart and one needs to select the patients properly as well as educate them about diet, exercise and a healthy lifestyle. Use the precise surgical technique suitable for that particular individual and have a defined post-surgical protocol. Many of us think that the patient desires a single stage correction. Our experience tells us that the patient is willing to travel the distance and undertake staged surgery if it results in minimal scar and a better long-term outcome. It is important that you are sure about this before you can convince the patient. Standardized post-op care helps us get consistent results and everyone in the team knows the processes to follow. This is very important chart which all the patients should be shown as they should be told about a balanced diet, staying physically fit, not to smoke and maintain a stable weight to have a good long-term result. A thorough clinical evaluation is very important and this has already been discussed by Dr. Varsha. In certain select cases, we do use a pre-op ultrasound to identify the amount of fat and the gland. Digital photographs and videos should always be taken for comparing the post-op result and also for long-term follow-up. These are some of the important considerations which all patients undergoing major surgeries, including liposuction and gland excision, should be careful about. And we also start Arnica 200, which is a homeopathic medicine, 3 days before and up to 3 weeks after the procedure. Digital photographs and videos should always be taken for comparing the post-op result and also for long-term follow-up. Pubertal gynecomastia is becoming common because of sedentary lifestyle, unhealthy dietary habits, and digital media invading our space. Another subset of patients who present like this are after massive weight loss, and few may have underlying medical causes for this kind of breast enlargement. It is important to classify the deformity and have a surgical plan based on the type of the deformity. Assessment of the quality of skin and glandular hypertrophy is important. The most commonly used classification by us is by Rohde-Rohrig, given in 2003, where he classifies grade 4 as severe hypertrophy, which would include more than 500 grams of tissue with grade 2 or grade 3 ptosis. The surgical options to consider for grade 4 gynecomastia in our practice have been a single stage surgery with free nipple grafts, which avoids scars beyond the perioral area, or a staged surgery that would mean removal of gland and liposuction to deflate the skin and then allow it to shrink or contract. Then a periareolar skin excision of the redundant skin is done and confines the scar to the NSE. This is the tumescent solution which we normally use for all our cases. Here is a 14-year-old boy who refused to go to school as he was bullied and touched inappropriately by his peers. He became a recluse and stopped going to school. He had an unusually large glandular hypertrophy. Liposuction and gland excision was done and this is the result which can be seen at about 2 weeks' time. and one can appreciate the amount of glandular tissue which has been removed. At 4 weeks, there is considerable amount of skin retraction, although some epithelial loss of the areola has happened. This will gradually heal with return of the pigment of the nipple. This is the result at 4 weeks, and the patient did not come back to us for a follow-up after that. This is a 20-year-old young man with weight loss of 15 kgs but with good skin quality. And you can see the 10-day post-op result showing good skin retraction and the wrinkling, which suggests that the retraction has happened very fast and will continue to happen over the subsequent few months. The surgical options discussed with this 19-year-old young man and his parents who presented with saggy breast after losing 18 kgs over 6 months. There was a history of frequent weight gain and weight loss, and the skin quality was poor. He wanted minimal scars, and he was consulted about the need for second surgery 1 year down the line if the skin does not retract. In the first step, no skin resection was done. The breasts have deflated, but there is still a lot of redundant skin, and he had also lost another 10 kgs of weight after the first surgery. He wanted a flat chest, and so a free nipple graft was planned. The position of the NSE has been marked on the chest. It should be at the or near the anterolateral part of the pectoralis muscle. A full thickness 3 cm NSE graft was harvested. This was combined with excision of the residual gland and extra redundant skin. About 3 mm of skin was circumferentially deepithelized, followed by a circular purse string suture to achieve a tension-free closure. An area of 3 cm was then deepithelized, and the free NSE graft was applied to the previously marked area on the chest. This is the result on the table showing the NSE grafts in place. This is the amount of redundant skin and gland that has been removed. The result 3 weeks after the operation. This gentleman presented to us again after massive weight loss with large ptotic breast. So the plan was to do a single inferior periareolar incision with liposuction and gland resection. The option of a breast reduction was also discussed with him. In the first stage, no skin resection was to be done. The patient was counseled about it, and pre-operative photo documentation was done. We had in fact marked him for reduction mammoplasty, but the patient changed his mind as he did not want many scars on the chest. A thorough liposuction along with gland excision was done in the first stage. And almost 2.8 liters of fat was removed along with the excision of the fibroglandular tissue. This is the patient at 6 months post-op, and one can appreciate the deflated skin. He was advised about healthy lifestyle changes, including a balanced diet and exercise. You can appreciate the marked deflation of the breasts. This is at 1 year's post-op. In the second stage, a circumferential periareolar skin incision with liposuction and isolation of the NSE on the subcutaneous tissue will be done. The circumferential skin excision will result in a periareolar scar. This is the patient preoperatively. A thorough liposuction is done on both the sides. A circumferential periareolar skin incision is made, and the chest skin flaps are dissected all around the NSE. Remaining fibroglandular tissue is excised. The NSE is pedicled on the subcutaneous tissue, and secured to the chest wall in an appropriate position marked earlier. Radial cuts are made in the chest wall skin and tailor tacking is done circumferentially around the nipple. The extra redundant skin is excised piecemeal to accommodate the skin around the NSE circumferentially. The process is repeated on the other side and symmetry ensured. This normally results in a lot of pleating around the areola. The skin pleating can be appreciated, but it will correct over time. Measurements were done to confirm the correct location of the NSE, and the process is repeated on the other side. The amount of skin and subcutaneous fat excised in the second stage can be seen. Final result on the table can be appreciated. On completion, the NSE was symmetrically located on the chest wall. This is after stage 1 and this is after stage 2. One can appreciate that the nipple areola complex are symmetrically placed, but there is some discoloration of the NSE. The ischemic changes to the nipple on the left side were more but healed over a 3-week period. This is showing after the first and the second stage 1 year apart. You can see the result at 6 months after the second surgery. Here is a patient with morbid obesity and wanted to have a flat chest. Bilateral simple mastectomy was planned along with an NSE graft. The 2.5 cm diameter NSE is harvested as a full thickness graft. This shows the simple mastectomy being done and the mastectomy specimen. The excised specimen on both the sides weighed almost 4 kilograms. This is the final closure before the NSE is applied as a full thickness graft. A tie-over dressing is usually done to facilitate the take-up of the NSE. These are the pre and post-op pictures of the same patient. There are long scars, but the patient can wear t-shirts of his choice. The early results show the NSE taking up gradually and there is a pigment loss at some areas. Most of these patients are very happy with the outcome because they can wear well-fitted clothing as per their choice. The actionable takeaways would be to educate and counsel the patients, calibrate the patient's expectations to what can be achieved, avoid scars on the visual part of the chest, except in cases of body contouring procedures, and plan a staged surgery with the use of periareolar scar and free NSE graft, which works very well in selected cases. We look forward to hosting you in Delhi for ASurg 2024 in the end of March. Please register if you still have not, as it is going to be a global meeting with a lot to learn in aesthetic surgery. Look forward to seeing you in Delhi very soon. Thank you.